and welcome to the ECIST podcast. Today we've got Angus Gartshore with us, who will be talking to us about how he set up mental health MaDE, his experience, what the benefits are brought, and learning more from him. So I'll let Angus introduce himself properly.
Thank you, Jen. My name is Angus Gartshore. I'm the Director of Delivery Improvement at Camden, Islington Mental Health Trust, and my main focus is on improving patient flow through our acute beds.
Thank you very much. Some of the people listening may not have come across the term MaDE, and it'd be great if you could explain what it is and why you think they're a good thing, if that's okay.
Yeah, no problem. So MaDE stands for Multi-Agency Discharge Event. It was originally set up in the acute sector, so the acute hospitals, and I think it's a good thing because it brings the sort of system together of an area, so it's a shared problem rather than one unit sort of taking ownership of a difficult discharge. So it kind of brings everybody together and people work through a problem and a difficult discharge to try and resolve it together.
Thank you. So they did start in the acutes and they've moved into the kind of mental health kind of community and teams. Can you tell me a bit about the background to how you started your mental health MaDE meetings? How and why, basically?
Sure. So in Camden and Islington, probably similar to lots of mental health trusts, we had a high number of out-of-area placements, so our patients were going all around the country. We did a sort of a data analysis of who was in our acute beds, and we kind of worked out that we had a high number of long stayers in our bed that was kind of taking up over 50% of our bed base, so blocking beds, and many patients were going all around the country. I was kind of tasked with trying to resolve this. So I looked at what other mental health trusts did. I also looked at our kind of 3 acute trusts in Camden and Islington, which are the Whittington, UCLH and the Royal Free, and saw what they did to improve their discharges. And that's where I came across the MaDE event. So I kind of sat in on a couple of those, one at UCLH and one at the Whittington, and saw how they functioned. And I thought, actually, bringing the local authority, commissioners together with the kind of the community teams and the inpatient teams together to resolve a problem about discharging could be quite easily transferable into mental health. So I just basically pinched the idea and set up a mental health MaDE within our trust to kind of resolve our sort of difficult to move on patients and try and get down our high number of over 50-day stayers.
On a very practical level, what does that kind of mental health MaDE look like? Who's there? What do you do? Just kind of for those that are thinking of starting.
So we started off, I mean, the acute hospitals do a daily MaDE, the ones that I saw. I thought actually there's the length of stay in mental health. It is longer than in an acute hospital. I didn't think we needed it daily. I thought actually probably weekly was good for a mental health system. So to sort of introduce the concept to my colleagues, we started off with a big sort of what I call a launch event. So we divided our patient groups up into our both boroughs, our London boroughs, so Camden and Islington, and we spent a day working through every patient over 50 days. Did Camden in the morning, Islington patients in the afternoon. We had the support of our medical director and our chief operating officer from the trust. We had senior matrons and inpatient consultants from the inpatient teams and their equivalent in the community teams. And we also got in kind of senior people from our local authorities and senior people from our local commissioners. So we essentially went through every single patient over 50 days, worked out why they were in an acute hospital, what the treatment was, whether they should be there or not, and if not, what the plans were to move them on. So we moved on from essentially that initial sort of launch event, which took up a whole day, to a weekly event, which is much shorter. It's about an hour, half an hour per borough. And we go through, we've dropped it down to everybody over 40 days. And we go through everybody over 40 days with matrons and inpatient ward managers, community team managers, a sort of a more junior local authority and commissioning representation. We go through everybody over 40 days on a weekly basis, work out, have they got any barriers to discharge? If they have, what are they and who is resolving it? And that's it. And we do that on a weekly basis.
And in terms of kind of prepping for the meeting, now it's over 40 days, do they get a list or do they just work through the patients themselves?
Yeah. So the day before the MaDE, ours is on Thursday morning at 10 o'clock. I send out the list on a Wednesday morning, and we have in Camden, Islington, we have a sort of a bed state dashboard which lists all patients in the bed. So I go through that, everybody over 40 days. Everybody that we're going to be talking about goes out the day before, so everybody's kind of prepped and ready. And we don't use it as a sort of a clinical discussion. So if it feels like I chair the meeting, so if it feels like it's delving into a clinical discussion, I kind of suggest to the people having a conversation outside the meeting to kind of go through those. It's very much a very task orientated, practical session. So it's kind of what are the barriers, who's resolving it, and what are the timescales.
In terms of accountability for actions, and I've been fortunate enough, I've observed your meetings, so I know the actions get recorded and get done, but just how do you keep people accountable for actions and keep things moving?
Okay, so I kind of chair and minute, and I kind of task people who's doing what and timescales. I follow up on a weekly basis at the MaDEs. If I feel something is not kind of progressing, then I escalate to the person's kind of more senior managers, and ultimately we go around to the relevant directors.
What benefits have you seen? Because you've been doing this for a while now, haven't you?
Yeah, since we've been doing it since our first sort of launch event was December 2018. We, as I said, Jen, earlier on, we kind of set it up to kind of reduce our number of long stayers, so those over 50 days. In December of 2018, we had 96 patients on our bed base over 50 days, and between them, they took up 29,500 occupied bed days, which is an extraordinary amount of time. Monday this week, that number was down to 50 patients over 50 days, which is still a large number, but the occupied bed days that they are taking up is 9,500. So you can see we've considerably reduced the number of real long stayers on our beds. And actually, the biggest impact is our kind of our need for out of area beds is pretty much eliminated in Camden, Islington.
So a huge benefit for the local patients and local and also local acute trusts and people that are waiting to access beds. You're treating people in their area, you're getting them out quicker. So just an enormous win for patients and local services and their families. It's difficult, isn't it, weekly in terms of attendance and busy diaries. How have you, because obviously there's massive benefit, you've got relationship building, but how do you get people there and how do you keep them there?
I think right at the beginning, it was quite tough because the kind of feedback I got from teams was actually, Angus, there's people, the reason people are in hospital is because they're not well, and they need to be there. So I try to sort of talk through about actually by making capacity and improving our flow through our acute wards, it means that we're not sending patients around the country so that they can be seen, in a local bed when they need a local bed and their family and friends can visit them. And actually we can kind of, it's a better kind of standard of care. We know what we're kind of doing with our patients. Also, I kind of think one of the big things right at the beginning is we had a couple of very quick wins. So I told you that the medical director was there. So I think our trust, like many other mental health trusts, takes the kind of ownership of very difficult to manage patients on itself and thinks actually they're very complicated people. Nobody else can manage them. They're best with us. So we had someone with Huntington's in one of our acute wards. The medical director turned around and said, actually, that's not an illness, not a condition that we should be treating in an acute psychiatric admission ward. They need to go to a placement. And we had a very senior commissioner from the relevant borough who said, yeah, that's correct. You go find a placement and I will, without prejudice, agree the funding here and now. The ward found a placement the very next day and the patient moved within 72 hours of that placement being found. So I think the inpatient teams and the community teams saw that this kind of change happened really quickly. So they kind of bought into it very, very quickly. And I think very rapidly, because we moved on a number of very long stay patients, our flow through our wards improved kind of exponentially. And so people will be able to access beds. And I think it's because they saw those quick wins, they kind of bought into it. It does have to be said that right at the beginning, when we did our MaDE journey, there was a lot of blaming culture between the two inpatient and the community teams. The community teams blaming the inpatient teams and saying, you know, you invited us up to discuss our patients and then you kind of delayed and we're left hanging around. And the inpatient teams saying the community teams never do anything. Actually, kind of 2 years down the line, there is a lot less blaming between the two sides, and it's kind of very collaboratively trying to resolve barriers to discharge.
That's fantastic. So just those quick wins, then to kind of really seeing them on the ground, the benefits to the patients.
Yeah.
And I guess some of it is now it's an hour, it's guaranteed to be an hour, it's effective, it's snappy,
Yeah.
so that they know that they're joining something that will only take them kind of, well, actually half an hour, because it's half an hour per borough, isn't it?
Yeah, it's half an hour per borough. I mean, I think the pandemic helped that. You know, we used to do the meetings face to face. It's now all on Microsoft Teams. And I think actually thinking about it, I think it works better on Microsoft Teams. It means, you know, we're not pulling people out of wards, we're not pulling people out of their community teams. The commissioners are kind of where they are, the kind of local authority is still there, so no one's trekking around. So it's a very focused half an hour slot for your borough.
Yeah, fabulous. A couple more questions. In terms of where you spot themes and issues, how do you feed that into the kind of strategic discussions for things that might need fixing longer term?
So we have what we've set up is our weekly MaDE that I described to you, Jen, but we've also, because of the benefits we felt having our medical director at that initial launch event, about a year ago, we started what we call a sort of a super MaDE, which looks at the top 10 longest stayers in each borough. And Vincent, our medical director, he supports that and kind of helps us kind of think through. And there are more senior commissioners and more senior kind of people from the local authority, and we can spot the kind of the trends, as you describe, about kind of what are the issues, particularly for Camden and Islington. We have a high number, and we've kind of spotted over the 3 years, we have a high number of chronic treatment resistant patients with psychosis that are going to sort of, you know, kind of long-term high dependency rehab units, what used to be called locked rehab units. And it's thinking about, because the commissioners are there, it's thinking about actually, should we be sending people to these units all around the country? Is there enough demand in the local area to warrant having that kind of provision within this part of our part of London? So we are teamed up at the moment in a partnership with Barnet, Enfield and Haringey Mental Health Trust, which are neighbouring trusts. Similar MaDE events are run there. I chair theirs as well. And actually, we've kind of got the learning from both organisations, and actually it's looking like we need some kind of a long-term high dependency rehab provision within North Central London. We've already got one purely for males, but I think what it's beginning to show is there's enough demand in North Central London to have a female-only unit as well. So we're not sending patients around the country.
That's fantastic. Thank you. 3 top tips for anybody starting out on this journey now, or kind of developing their MaDE model that they've already got.
I think the most important tip I think I've found is the way you kind of chair it. You kind of, if you kind of rush into it and are sort of blaming people are going to get turned off very, very quickly. You need to sort of approach it kind of fairly collaboratively. I'm a nurse myself by background, psychiatric nurse. I've worked in acute wards, I've worked in community teams, and I think it's being able to approach it on a sort of a level of understanding rather than just say, right, why can't this person go now? Why can't this person go? And I picked that up from the acute hospitals that I saw. So I went to Whittington, and the guy who chaired it was very informal, very relaxed about it, not blaming, and just basically offered support all the time. So if a ward says, we're trying to move this person on, we can't get anywhere with the commissioners or the local authority, I mean, they're there in the room, and so it's working together, I guess, and it's offering to help constantly is probably the best thing. Making sure it's all scheduled, everybody knows the invites, everybody's aware of what it's all about. I mean, when you set them up, you might have to do quite a bit of prep work, going to speak to people about the reasons that they need to be there and the benefits. But it's being just kind of persistent and dogged, kind of setting it up, getting organised, sending the minutes out, sending the actions out, sending the lists out, getting it all timed up. You know, it's just kind of persistence, non-blaming, and kind of helpful, and that gets people wanting to attend.
That's fabulous. Just a final question. Are you taking this any plans to develop this? What would you do next with it, or are you happy with where it's at?
No. So what I always wanted to do is actually get mental health discharging support on a par with acute hospitals. So watching acute hospitals MaDEs and actually seeing the reaction that acute hospitals get for blockages to discharges when people just jump up and resolve things immediately. And it's never felt like that's the same approach to mental health. So I think it's trying to get us on the same par with acute hospitals, so that, you know, if we turn around to a local authority or local commissioners and say, we have a blockage, please help us, I want the same response that acute hospitals get in a mental health setting. In north central London, we have Camden, Islington and Barnet, Enfield and Haringey, we've managed to worm ourselves an invite onto the North Central London Silver MaDE, which is what all the acute hospitals use in North Central London. So the North Mid, Barnet General, the Royal Free, Whittington, UCLH, for any of their difficult and blocked discharges. So we attend there, and any patient that we have massive problems and we can't resolve at a local level, we can take there and get support from our wider commissioning colleagues and acute colleagues, which has been really helpful and has actually helped move on a couple of real blocked patients.
Thank you very much. So thank you very much for your time today. It's been incredibly helpful, and I'm sure will be really helpful to those thinking about their own mental health MaDE structures. So a massive thank you, and thank you for joining us.
Thank you.